This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. I'm very pleased to have with us on the Psychcast today, Dr. Rebecca Brendel and Dr. Dyer, and they will be engaging in a conversation regarding the ethics of COVID-19, particularly as it relates to allocation of resources, which we have dealt with, as well as how we can start to think about the ethics of taking the vaccine and distribution and trustworthiness. Guiding this discussion today will be Dr. Carol Bernstein. So please stay with us for what I'm sure will be a very informative discussion around the ethics of COVID-19.
Thank you very much, Lorenzo. I'm Dr. Carol Bernstein. I'm a professor and vice chair for well-being and faculty development in the departments of psychiatry and behavioral science and obstetrics and gynecology and women's health at Montefiore Medical Center and the Albert Einstein College of Medicine. I am also a past president of the American Psychiatric Association. I'm delighted to be welcoming our guests today, as Dr. Lorenzo Norris mentioned, and I will have them introduce each of themselves first before we get to our topics. Dr. Rebecca Brendel.
Thank you, Dr. Bernstein. It's my pleasure to be here with you, Drs. Norris and Dr. Dyer today. I'm Rebecca Brendel. I'm the Director of Law and Ethics at the Center for Law, Brain, and Behavior at Massachusetts General Hospital, as well as the Associate Director and Director of the Master of Bioethics program at Harvard Medical School.
Thank you. Dr. Dyer.
Hi, I'm Dyer. I'm Professor of Psychiatry and Behavioral Sciences and Vice Chair for Education at the George Washington University School of Medicine and Health Sciences in Washington, D.C. And it's my pleasure to be with this group.
Well, thank you very much. Clearly, there are a lot of ethical considerations that we have to talk about with regard to COVID-19. There have been many in the media and the news, but I always like to start these conversations by hearing just a little bit about your own interests. So, Dr. Brendel, could you just speak? I know you have a long and illustrious career, but could you just tell us a bit about your particular interest in ethics and why you got involved in this aspect of psychiatry?
Well, let me try to put this in a nutshell. Otherwise, I'd eclipse our entire podcast talking about my interest in and love of ethics. Let me say that from early on, before I even went to medical school, I was a philosophy major in college, and I became really fascinated with the kinds of decisions that we make about healthcare, then later on in psychiatry. And now, as I've gone on in my psychiatry career as a forensic psychiatrist, as a psychiatrist who practiced on the consult liaison service at Mass General, many of the issues that provided the most challenges in consultation and around patient care had to do not with the psychiatric care per se, but with many of the surrounding issues and kinds of decisions that we had to make. And so that led me really to spend a lot of time in ethics going forward, some wonderful collaborations with colleagues in psychiatric ethics, including Dr. Dyer, who I'm delighted to be here with today. And when COVID came, as a teacher of ethics, really being immersed in a living laboratory, so to speak, unfortunately, one with grave consequences for human life and suffering, about how we can reframe and reshape our ethics to be responsive to the challenges that we're facing today.
Thank you so much. And Dr. Dyer, the same question to you.
So my interest in ethics goes way back also. When I was a resident in psychiatry at Duke, I was doing a PhD in medical ethics concurrently. And that happened to be the time when the APA reformed its ethics committee and dealt with a number of important issues in terms of how do you articulate a code of ethics for the psychiatric profession. And what the committee decided at that time was that because psychiatrists were physicians, it would be the AMA code of ethics with annotations applicable to psychiatry, which is what we've been using for the last 40 some odd years, updated as particular situations emerged. So it was a great pleasure to get involved in the APA early on when I was a resident still, and to see the importance of a professional organization for defining and articulating the standards of practice in terms of an ethical formulation.
Well, thank you both very much for that. I'm sure we could talk a lot more about your interest in ethics. I'm going to ask a broad question first, so I hope you'll forgive me for this. But as the COVID pandemic has emerged and erupted, there's been a lot of talk about ethics. Can you briefly, since I know there are so many topics for us to cover, talk about how the standards of care may be ethically different in the course of a pandemic like this than they are in the usual practice of medicine?
One of the things we could say about the usual practice of medicine is that it's doctor and patient in an individual relationship. And doctors, because of their commitments to their patients one-on-one, one after another, are very dubious about a mass disaster situation in which the decisions that have to be made are not just about the individual patient that is in front of us, but in terms of the well-being of society and the relationship of us as well as our patients to the larger community and the larger society.
Yeah, I think, when we, as a teacher of ethics, we used to start our academic year with what we called an ethics simulation, which was a case that we gave to students working in groups, thinking about what ethical principles we'd apply if we were in a situation of scarcity, right? And in doing so, students would sit there and think, well, this is what we would do. But come on, it's 2019, it's 2020, right? This is the United States of America. Their healthcare, right? We have so many resources. This is never going to happen here. And so when we were thrust into the spring of 2020 with real shortages, right? Real shortages that left us reading in the newspaper about getting ventilators from the local animal hospital to make sure that we would have enough for people, right? And reallocating ventilators from neonatal ICUs to makeshift ICUs all over the country. Right? All of a sudden, we were faced with the reality, right, about how we were going to think about allocation when there wasn't enough for everyone. And that's something that really shook the system, right? The focus immediately, as you'll see, and we can talk about the evolution of this, but the focus was immediately on how are we going to do this work that we've been imagining and using to shape our ethical discussion for all this time when we actually have to do it. And that's when the ethics really was front and center. I couldn't walk my dog in the morning without my neighbors, many of whom are physicians, saying, okay, well, what are they going to decide today, right? All of a sudden, I was the most popular person at 6 a.m. on my street. So I think that really reshapes how much this captivated everyone's interest and brought medical ethics front and center, because it was fundamentally antithetical to our desire to save everyone, to push forward with medical technology, to save life at every cost. And really within the public spaces, certainly in Massachusetts where I live, to think about access to healthcare and broadening access for many. So I don't know if that helps give it a little bit of a context of why this was such a pivotal moment for medical ethics in the public sphere.
So basically, the shift in thinking was driven by the scarcity, because you couldn't just look at an individual patient and say, what are the ethical considerations for this particular patient? We have to think about the ethical considerations, not just for this patient, but for society at large, because of the scarcity. Is that correct? So were we really I'm sorry, Alan, go ahead.
Yeah, well, I was going to say we're wearing two hats when we talk about ethics, because on one hand, we're talking about the decisions that we make as individual physicians and as people in our day-to-day lives. And on the other hand, the larger questions are policy questions, which aren't questions that we as physicians will make. We will become part of a larger conversation with society, and we're very concerned about how the decisions will unfold. But that's very different from the decisions that we make in our role as physicians with our patients.
But I think, or at least sort of from, if you forgive me, a layperson's perspective, we hear that the instructions to the EMS team are that if somebody is dying, they shouldn't even bother to bring them to the hospital. What can you say about that? Because that is, although it has societal implications, that's an individual decision that an EMT or a physician has to make.
And this was really a shift in the discussions we were having in Boston. In particular, we would have a meeting every week of leaders in ethics and involved in how we were going to make these decisions. And of course, where you are, Dr. Bernstein, in New York, we were watching very closely about what was happening and learning from our colleagues there. Since you were a bit ahead of us in terms of the peak of the pandemic. But really the notion that it could actually happen that an individual physician would be in a position where they would have to deny care to a patient and eclipse the possibility of rescue or survival from that patient because of a societal prioritization that came between individual physician and individual patient, as Dr. Dyer is talking about. That was something we always knew was possible. We always talked about things like crisis standards of care. We never really imagined the reality that would face us front and center. And that was really the place that caused not just a lot of distress, right, but a lot of re-examining and revisiting the ways in which we make those policy kinds of decisions.
So what guidance did you decide to give people about that? I know it was hard, but what is the guidance?
So maybe we could use Washington as a third pole in this discussion, because we didn't quite get to the point of rationing healthcare. The whole idea was to avoid by pre-planning as much as we could, and it wasn't clear that it would work out, so that the individual physician didn't have to make that decision. And so there were committees that were set up that would talk about the algorithms that would be used in making the decision for who would be admitted to the ICUs, so that the doctors that were actually caring for the patients, let's say that it didn't happen that they had to minimize care, but that was minimized, that they would be directly involved. And fortunately, we didn't get to that point. But another thing that we did in Washington was that all of the hospitals got together, so everyone was using the same algorithms, so that there wouldn't be any opportunity or temptation to jump from hospital to hospital or shop around where you might get a better situation.
Yeah, and that's really the experience that we had in Boston as well. The Department of Public Health really took leadership on crisis standards of care. We prepared, as I talked about earlier, we tried to gain and pool as many resources as possible, both to avoid cherry picking, so to speak, about which hospital to go to. And then also we had enough time. We had enough warning to be able to engage multiple voices from the community in how to establish those crisis standards of care, which were adopted but ultimately not implemented. So we were able to avert the crisis, but begin to have these really important conversations.
I know I keep pushing you on this, and I'm really glad that we were in a circumstance where it didn't have to be implemented. And one important thing that you both alluded to is the fact that there was of the importance of common agreement about the process to be followed was really significant, so that it didn't create a multi-tiered system where one hospital did one thing and another hospital did another, or that one doctor did one thing and another doctor did another. But did you come up, and I've also heard the almost cases in California. None of us are there right now, but I haven't heard that it has come to this. but I am hearing about the discussions. Are there any things that you can say about the principles, even with the great relief that we have at the moment, that we haven't had to go there yet? And hopefully we won't have to, but just curious.
Well, I think, you know what, let me start us out, and I'll invite Dr. Dyer to jump in on this, that in a situation of urgency and exigency coupled with scarcity, really we turn to what we would call a utilitarian approach initially to thinking about allocation. Mostly meaning that we get the most bang for our buck, right? That we maximize our outcomes. So we avoid situations in which we would allocate scarce resources to those who could not benefit. And so what we ultimately try to think about, right, is the most good for the most number, which might mean that in the process, there are certain individuals who get left out. We can come back to that and talk about why that becomes problematic. And that's really where a lot of the concern came up. You know, that seems like an easy principle. Number one, right? However, we weren't so sure early on who was going to survive. So survivability became a really important metric. And then we also had to think about survivability for what period of time, right? And so that's another place where there were big debates about how we would define who would come first, so to speak. And so that's really where a lot of this started. And I'll ask Dr. Dyer if he wants to jump in on this. This is something he's given a lot of thought to.
Yeah, and I think the question, Dr. Bernstein, that you're asking is, we're in a pretty good place so far compared to what we might be as the curves escalate upwards rapidly, and we may be facing the things that we haven't yet had to face. As Dr. Brendel said, it's a utilitarian calculus, and one of the things about the utilitarian calculus, the greatest good for the greatest number, it's hard to say exactly what good is, and it's hard to calculate how that's going to play out. It's really very challenging. And I think one of the principles, I mean, we're talking about in a larger sense, justice, transparency, solidarity, and community engagement. Who decides these issues? And how are they going to be decided? I think if we go back to the some of the early decisions in the renal dialysis, when that was first available, and before Medicare paid for it, there were committees that were set up that tried to make these decisions about who was worthy of getting the care that was available. And they were called disparagingly, and I think the disparagement is rightly labeled, God committees. And the committees involved physicians and nurses and members of the community and clergy, of which denominations, various denominations, and there's no way to get it exactly right. And the way that was ultimately solved was by making it available in Medicare, so that those decisions, the more resources became available, so that those hard decisions could be avoided, or at least kept at a greater distance. Something similar happened in psychiatry with PTSD. Before it was a recognized diagnosis in DSM-3. People that had those symptoms, usually Vietnam era veterans, had to specifically sue the government for their care. And that changed very much when the resources became expanded. In a sense, we're in a similar era right now, that resources have been perhaps artificially constrained over the last several months. And now we can hope and imagine that there will be a major push to make resources available in ways that they haven't been heretofore.
I'm going to switch gears slightly here and move from, if you will, the life and death ethical decisions to decisions about the vaccine rollout, which here probably gets, it hints at the scarcity question, but more at the issue of who gets it when, I guess. So what are the general ethical challenges around this now, the vaccine distribution? I think there's a fair amount of confidence that ultimately there will be enough vaccine. And then we can also talk about vaccine hesitancy ethically. But could you comment on that situation as well?
Well, one of the things to say about it is that it's both a question of who gets it in terms of who will benefit from having it, and the other is what is the good going to be of forestalling the spread in the population. So part of it is balancing those two considerations against the resources that are available.
And this is in particular, I think it brings up a number of considerations we have about who ought we to be concerned about and to take care of because they're in particularly vulnerable populations, right? So individuals living in institutionalized settings, from nursing homes all the way to correctional facilities, really had very little ability to, and in many cases, no ability to find an alternative that would be safer, right? And so they bore a disproportionate impact of COVID infection at the time that there was the shutdown and people were confined to their living spaces. Also, we think about individuals, this of course affects many chronically mentally ill individuals who live in group or semi-group, semi-institutional kinds of settings or congregate living settings. So I think with the vaccine, there's this added question about what the risks are to different populations. Certainly these cohabitating individuals who are living in these group and institutional settings were at much, much higher risk. Even though, right, then there's the question of healthcare workers, where by the time the vaccine came out, we did have good data about risk stratification, who is at the highest risk, and also in the setting of the availability of PPE, right? The rate of transmission for those who were not necessarily doing aerosolizing procedures and having prolonged patient care contact was actually much lower. And so on the one hand, we say, okay, we need to vaccinate healthcare workers so they don't spread COVID to others, and they are still available to care for patients. On the other hand, the data was a little more complicated about that because there were clearly levels of individuals whose clinical contact or care contact did not place them at the same kind of risk that persons with higher vulnerabilities had. And so that was something really different. And it was also really different in the setting of asymptomatic carriers and the lack of community testing to really understand, right, the second part of the conundrum that Dr. Dyer brought before us, really about who, in vaccinating who, would we really be decreasing the spread and the toll of COVID within the community. So there were so many different pieces, which drives home the point that we can come up with a lot of principles and a lot of ethical judgments and ideas, but that moral judgments, right, very much turn on non-moral facts, right? And so the lack of availability of surveillance testing, for example, in many settings turned out to be something that limited our ability to even implement, right, the ethical choices or the goals that we had set up for ourselves.
Well, similarly to the question that I asked before, and Dr. Dyer, maybe you can take this, what principles then do you espouse when you're trying to weigh all of these different considerations about, who has access, who needs it the most, where they are, et cetera?
Right. So when we identify principles, we generally identify them by a word or a phrase that connotes a very complex situation and tries to distill it into something much simpler. Justice, for example. Justice is important, but justice is very complicated. And what does it mean? In terms of these allocation decisions, I think one of the principles that becomes important, it's always important, but becomes perhaps more important, is transparency. What are the algorithms and how are decisions being made? And we can argue with with the decisions, we can argue with the algorithms, we can argue with the principles, but we can't do that unless we know how the decisions are being made. So transparency becomes a very important consideration, especially in a situation like this. Another principle I think that's very important is community solidarity. The American philosopher Wendell Berry says the smallest unit of health is the community. And if we stop and think of that, what is the smallest unit of health? We might be tempted to say it's the individual. We might be tempted to say it's the cell or something like that. But Wendell Berry says it's the community. And I think in this aspect of a pandemic that affects everyone, community solidarity becomes very important, not only in terms of each of us getting the care that we hope for and need, but that we recognize the needs of others as this unfolds.
Well, I don't know whether this is really appropriate to do, but I experienced a circumstance this morning that gets to your community piece, Dr. Dyer, in a sense. I was in a small coffee shop, which probably had safe spacing for 4 people, one I go to every day. And a woman approached the counter to give her order. I couldn't see her. She was in the back. And the server said to her, do you have a mask? And she said, oh, no, I don't have my mask with me. And another minute or so went by and he said, well, would you like one? I will give you a mask. And she said, no, my mask is in the car. And I just said, could you please give her the mask for the benefit of all of the rest of us? Now, I mean, I felt a little weird about doing that, but here we're talking, I think, also about the ethical responsibility, if you will, or maybe I'm not using the term correctly, that we have as members of the community, not just that people have about making decisions and principles like this. Would you say that that is a significant piece of this discussion?
Well, clearly a significant piece as it's played out, right, has been how we reconcile this notion of American individualism, right, and individual freedom with these notions that Dr. Dyer's been talking to us about community responsibility, right, and our obligations to others. And so and then even beyond that, right, as a physician, your responsibility in this scenario to public health and to advancing the public health, right? So how do we really start with the science, right, and start with the conversation that says it's actually not all about me, or it's not all about one person, but that we actually do have at least reciprocal obligations, if not, primary obligations to the health of those around us. And I think what you're bringing up is a really important part, and of why, in the U.S. we've had one of the reasons why we've had such. We're still having a conversation about face coverings when we know that masks work, right? And so that how do we square the ethics with the legal principles and some of the values that our society is formed on.
And that's a situation that leaves you, Dr. Bernstein, but leaves all of us scrambling when we're in a situation where people refuse to wear masks or decline to wear masks, or where even the wearing of masks has become politicized. And I think that challenges the notions of the common good and responsibility that we have to one another. But I think in the broader sense that Dr. Brendel just mentioned, in terms of everything we know about public health, I mean, everything that we've learned about infectious diseases since the time of cholera and all of the infectious diseases, the childhood diseases, all that we've learned about HIV, SARS, and H1N1, that are absolutely applicable here, and things like contact tracing, which we haven't been able to do because of the tension between individual freedoms and rights and public responsibilities and the common good.
Well, that may sort of easily segue into the question about what does it mean for the public health system to be trustworthy? And is that part of the challenge that we have, why people, and to some extent, are struggling with this, my individual right versus the common good? So could you touch base about that a bit?
Well, let me start us out, and then we could have a conversation about this. But the question here, right, is it starts really with the transparency that Dr. Dyer was talking about, right? That if you don't know what's happening, and these are life and death questions that we're making, and they're happening in a black box, right? How could you trust the system if it's not predictable, if it doesn't include public engagement, community values, and the interests of persons and groups of persons, right? Communities of persons, using the word community in, of course, a broad sense. And then how do we then, right, rather than just saying trust the system, go along with what we're saying, how do we, as those in the medical profession, both show, right, and prove that others can trust what we're doing, right? So we start by making it clear the parameters we're using, and we have to hold ourselves, right, to exercising those values and holding ourselves to them. And then we really have to be clear about what is the science, right? We have to be clear about what the responsibilities will be. For example, in the vaccine trials, what would happen if somebody got ill? Would make sure, right, that there's access to treatment and to medical care, regardless of insurance status, right, or regardless of where one is living or one's background, and to really bring forth in very clear terms credible evidence about both the contagion and the features of COVID, and also about the efficacy and side effects or experiences of those at this point who go on and do have vaccination. That would be one of the first steps.
One of the things that's very important in public health, and I think of my friends in ministries of health and other places, that they spend a lot of time in communication, picking up on the theme of the importance of the science and the accuracy of the science. But not only the ministries of health or the health departments or the government agencies, but working closely with the media so that the messages are very consistent. This is what you need to do. I mean, we might think of, again, some of the other viral infections like HIV and H1N1 and SARS and so forth, and the importance of a clear and consistent message in terms of this is what needs to be done. And we have a very, being a federal kind of government, a lot of different voices saying a lot of different things, which is only complicating the challenge that we face.
Well, that was part of a question that I was going to raise, because it's part of transparency is also accountability. And when we talk about transparency, we're making an assumption that if we say that something is transparent, that it is truly transparent, as opposed to having fake news, as it were. And I think part of what's happened here is that the public in general has lost faith in understanding what's transparent, or what it means to be transparent. So how do we, as a nation, as a country, as public health officials and doctors, go about trying to restore that faith in truth and transparency? Because those are so central to what you're talking about with these ethical challenges.
Yeah, that's a big question, and we'll see how that plays out, and we'll see what works, right? Another living laboratory, so to speak. But some of the things that we can also do, in addition to working with communities and working to disseminate information, is also to work with other trusted institutions and persons within the community to disseminate that information, right? So one of the things that's been effective and needs to happen, for example, in predominantly Black communities where there's really justifiable mistrust of the medical system for so many reasons, is really work with faith leaders and religious communities, those who are trusted, to show and to answer the questions and to partner and to establish, right, a trust in the science and in the accountability, right, and the responsibility for treating persons fairly and equitably, as well as actually providing care, right, and based in science. So that's another thing that sometimes we don't think about, right? As physicians, we are so used to thinking about, well, it's science, right? It must be trustworthy, and there are giving people the opportunity to question through other trusted leaders, right? To show and model relationships, right? So in Philadelphia, this weekend, it's just on public radio, Black physicians going into the community to actually provide vaccinations, right? Really, really important to not just to tell and to quote science, but to show, and to show through relationships and through actions.
Yeah, the importance of example. Another thing I think that's important in the discussion like this may be counter to the best intuition is that the message needs to be simple and consistent. And we're used to thinking of the complexities, and it's important to think of the complexities, but it needs to be a simple and consistent message. And I'm reminded historically of smallpox vaccination. That one of the reasons that we're even here to be able to talk about this perhaps is because George Washington vaccinated the troops, and Abigail Adams had to decide, was she going to vaccinate her children and take the risk of that? And some of the children she did, and they survived, and I think one of the children she did not and did not survive. But it's kind of a daunting prospect. You say they're going to put something in your arm and you don't know exactly what it is. I mean, we sort of have a sense of what mRNA is, but a lot of people don't. And it's not like vaccinations are daunting prospects, really. Those of us who have faith in science and know something about how to look at the data and try to make sense of it are privileged in a way that somebody that may be more vulnerable to the fears and uncertainties may not be.
Well, so I have two questions that may be related and may not be, but one is, how do we know when people are being treated fairly and equitably? Since that's one question. And the other, which is a little bit of a side, is, how to ethically deal with the challenges of people who are anxious or resistant or don't want to take the vaccine.
Well, you gave us both pause in answering those questions, so they were obviously outstanding questions. I would say that how that one of the problems that we have is we need to collect better data, and we need to be really clear about what we're doing and how we're doing it, right? So in the vaccination realm, we already had a fair amount of distrust within our society about vaccination, right? There is this mystery. There's been a lot of mixed credibility science around it. And so really being clear about how many vaccines have been administered and telling people, preparing people for what side effects might be, right? So that people are ready for them, not surprised by them and saying, you didn't tell me, but also really keeping data and being clear about what serious side effects are, what they look like, and what happens at that time. And then really keeping demographic data, looking at the administration of the vaccine, measuring that against the policies, right, and the prioritization of vaccines to make sure that the allocation is actually happening in the ways that we said it was happening, and if not, correcting course, and showing a real engagement around that we really, we do what we say and we say what we do, right? And that those two conversations together become really, really important. I'll stop there. I'll let my colleague take the second question or jump in on the first one.
Well, one of the things I think is important to say, I mean, again, who do you trust, whom do you trust, and how do you develop trust? And one of the things, and maybe we think a little bit about psychiatry's contribution to ethics as well as ethics' contribution to psychiatry, that one of the things that we as psychiatrists take to be very important is dealing with people's feelings and fear and uncertainty and anxiety and whatever that is. That's part of your question, Dr. Bernstein. And then to recognize that when we think a medicine might be useful to somebody, it's a process of informed consent. It's informing them of the information with the recognition that they have a decision to make, and it isn't a decision that we make. And one of my patients said recently he didn't want a colonoscopy. And I said to him, you don't have to have a colonoscopy. But most people feel that the inconvenience of the colonoscopy is worth the benefit. And they began to think of it that way. And it's the same thing once a patient was on lithium for bipolar disorder. And I said, you don't have to take this. And of course, we know we might write the prescription, but the patients may not fill it. They may not take it. And she said, oh, I didn't realize that. No one ever said that anymore. And I said, but to follow up, you realize the consequences of not taking it. But it isn't because I tell you need to take it. So I think a similar kind of thing, that you can't just tell people this is what they need to do. They have to see the benefit for themselves as well.
And, on
No,
that,
I
that
think.
point, oh, sorry. I think
Go ahead, Rebecca.
on that point, right, we think a lot. On the one hand, we've been talking about trusting the science, trusting the facts, making a rational decision. And on the other hand, especially as psychiatrists, we know that feelings, emotions, experiences weigh heavily into these decisions. And so one of the ways in which we can have the discussion about the benefit of vaccination, for example, is to use both, right? What if I told you that this could prevent you from dying, the rational conversation, but then also really to engage the affective conversation, and not just about the individual themselves, but who do you love most in the world, right? And if it's a parent, or if it's somebody who is at a high risk or vulnerable, really asking, well, would you be willing to do this to potentially save someone else's life, right? Or prevent somebody who you love from getting sick, and really broadening the conversation just from the individual and a seemingly disembodied decision on the facts to one that really resonates with the circumstances and the important relationships in their lives.
Well, I think you're both talking about how important the communication is and what the communication is about and the relationship. And I would say someone made a comment to me, which I think is a very good way to start the conversation about the vaccines, is to say, what would make it possible for you to take the vaccine? So it's turning it around. It's giving the person, it's like you're saying, you don't have to take your lithium. You don't have to, do the dialysis, but this is what will happen. And I think it's also about, respect for each other, which has been, a huge challenge here. Are there some other issues that I haven't raised that you would like to mention before we have to wind this up, either of you?
One of the things that troubles me greatly is an issue that we haven't solved in decades in terms of the distribution and access to healthcare in this country. And in a situation where we have a global pandemic that's affecting everyone in one way or another, and a massive unemployment with health insurance being largely tied to people's employment and decisions that their employers make, this is something that we've got to figure out. And it may be, if there's any crisis, if there's any opportunity in the crisis, it will be the opportunity to think long and hard about how can we make a more just and equitable system and help people, everyone that needs it. And it isn't just that we need it for the healthcare that we get, we need it for the benefit that everyone gets from having a healthy population, a healthy workforce, a healthy military force, in the case of the George Washington example with the colonial army. It's something that's very serious, and it would be nice to say Medicare for all, but that's very complicated, or the government does it, or private insurance does it, or the private sector in some way, or how can we merge and recognize and reckon with all of these disparate concerns to come up with something that's better for everyone?
And I think one piece that I would also add to that is really about the importance of mental health in overall health, right? So that there have been a couple good parts to the story actually around innovation, access, and delivery of mental health care, in particular, the ability to implement telemedicine relatively quickly. And it turns out in ways that do help many patients access mental health care. But, our suicide rates are up, our overdose rates are up, our rates of violence are up, and we need to use this as an opportunity both to treat physical and mental illness, but also to think about the ways that we can reintegrate mental health care into overall health in ways that treat the whole person. And I do worry a little bit about on the one hand, it's been great innovation. People show up for their psychiatric appointments. They have access to psychiatrists who are far away. On the other, not losing the importance of the personal connection and the availability of in-person psychiatric care the same way that we've prioritized in-person physical health care.
Well, thank you both very much. I'd like to thank my guests, Dr. Rebecca Brendel and Dr. Alan Dyer, for a very stimulating discussion. And the last point you raised, Dr. Brendel, is one that we could have another podcast on. So again, thank you all. I'm Dr. Carol Bernstein.